As I said, today is session 5, and we are going to be discussing critical care outside the ICU, a rapid response. I would now like to welcome Dr. Saria to introduce himself and the panelists for today and to lead us further with the session. Dr. Saria, please welcome.
Okay, thank you very much, Dr. Kevin. As you said, my name is Dr. Peter Saria, anesthesiologist working at the CCBR at Dar es Salaam, and also a course coordinator for these oxygen series sessions. And today I would like also to introduce Dr. Rebecca Samuel. Dr. Rebecca Samuel, she's an anesthesiologist at Bugando Medical Center in Mwanza. We also have Dr. Gibbons Makisambwe. He's an anesthesiologist working at Mbeya Zonal Referral Hospital. He is currently doing his Master of Science in Critical Care at MUHAS. So I'm sure today this will be his area of interest. And also we have Dr. Leticia Komba. She's also an anesthesiologist working at Mbeya Zonal Referral Hospital. So together, we're going to take you through the whole of this session. But remember, this is an interactive sessions. Feel free to ask questions, feel free to contribute. We have some questions, some poll questions. We have some MCQs. Sometimes you need to respond. So don't feel shy to give your thought, whatever we ask a question. So welcome all. And so today, as Dr. Kevin said, we're going to discuss about critical care outside the ICU. We all know that sometimes we receive patients who are critically ill, either pre-hospital or even if it's within the hospital, pre-ICU. So we're going to go through to see what can we do in case we have a critically ill patient who is not in the ICU, who is in the ward, or a critically ill patient who is in a certain hospital who has to be transferred to another hospital or high facility, which has all the ICU or critical care facilities. So that will be our discussion today. And the practice changes objectives. So can you scroll down? Yes, please. So these are the practice change objectives. We need to understand about the definition of critical care continuum. We have also to understand about the oxygen saturation goals for oxygen therapy. I mean the SpO2 goals for those patients who are receiving oxygen, and also some terminologies like QSOFA, MUSE, and QCSI scores. These are the scores which are used in ICU or outside the ICU. We're going to see them and the importance of using them when you're managing patients who are critically ill. And also the signs and symptoms of life-threatening conditions, how to identify persons that can offer the time critical care, how to form a response, rapid response team or system in the hospital, and also the issue of policy, documentation within those institutions. And last but not least, if the times allow, is the practice and simulation, I mean. So starting with the definition of this terminology, I would like to welcome Dr. Rebecca, who is going to take us through the first session of these objectives about the definitions of the critical care continuums and the issue of oxygen therapy and the target SpO2. Dr. Rebecca, you're welcome.
Thank you so much, Saria. Good afternoon, everyone. As I've been introduced, I'm Dr. Rebecca, and I'm going to take you through the first part of this presentation. At the end of my presentation, we need to understand what is critical care continuum. But before that question, I want us to respond. Which of the following are considered critical patient care? So there are 5 options. I would like just to write what do you think the correct option among those 5. Then you just drop on the chat box for a few seconds, then we shall discuss. So you're welcome, participants, be free, just drop whatever answer you think is right for you. And as our role, we respect every response from every participant, so feel free to do that. Karibuni sana. So just write the letter or the option you think is correct to that question. Number 1 says error recognition, assessment, and decision-making for deteriorating patients. Number 2, rapid and timely intervention for patients at risk of clinical decline. Number 3, identification of clinical Karibuni jamani. I want to see some response in the chat. Does anyone think of any option? Andika tu kile ambacho nafikiri ni jibu. Asante Ntiga. Ntiga has responded number 5. I'm adding 10 seconds. If there's any other response before we proceed. Kama tulivyosema huwa ni interactive, kwa tunapenda kila mtu ashiriki kwa namna moja au nyingine, then tunaendelea. Okay. Asante Saumu Hassan. Umeona option? I think for the sake of time, kwa sababu watu tunakuwa na muda mfupi kuliko mambo tunayohitaji kudiscuss. Okay, asante Dr. Esther. I may opt all of the above. Thank you for those who have responded. So I think we all agree kwamba hizo options zote zinaelezea what is the critical patient care. So vyote hivyo vinavyofanyika ndio critical care yenyewe. Kwa hiyo tunaposema critical care maana yake nini? Ni hivyo vyote unavyovifanya. So chochote unachokifanya ili kumprevent mgonjwa asiende kwenye life threatening condition, you detect error, ina include hizo vitu vyote, error recognition, assessment, hayo mambo yote ambayo yamekuwa listed hapo. Hapo ukifanya yote, it means you are doing critical care to that patient. Okay, so the option 5 is correct. Let's proceed. Now we all know kwamba mgonjwa kabla hajaenda kwenye critical condition, hajaenda kwenye life threatening condition, huwa kuna zile signs ambazo mgonjwa ana present. Mgonjwa mara nyingi huwa tu hapati cardiac arrest suddenly, huwa kuna viashiria fulani sometimes before haja arrest. Kwa hiyo hivyo vitu ndio tunavyovitaka viwe detected mapema ili viweze kuprevent mgonjwa asiende kwenye life threatening condition kama cardiac arrest au respiratory arrest. So whenever you see such changes like abnormal vital signs, sometimes before mgonjwa haja complicate, hajaenda kwenye life threatening condition, if you rescue those changes, then unamprevent mgonjwa kwenda kwenye life threatening condition, lakini pia una improve outcome ya mgonjwa, kwa sababu asipoenda kwenye life threatening condition, it means the outcome of this patient itakuwa better. Na ndio maana tunasisitiza sana issue ya critical care kutolewa sehemu yoyote ile, kwamba ita prevent worsening ya mgonjwa. So let's see this, the other question. It says, how would you define critical care? Nadhani sasa hiyo tumeshajua. How does critical care occur? Then where does critical care occur? Then how does critical care differ from intensive care? Naomba kama kuna mtu ana respond yoyote kati ya maswali, you just write anything on the chat, then tuta discuss kwa kifupi. If you have any response kwenye hayo maswali, where does critical care occur? Then how does critical care differ from intensive care? Okay. Is there any response on those questions before we proceed? Thanks, Dr. Antiga. I have seen your comment. Thank you so much. So is there any response on those options? Okay. 5 seconds. If no response, then we proceed. Okay, so thank you. I think let's just proceed for the sake of time. So we have seen from the first question what critical care was. What is critical patient care? That is the care given to a patient to rescue a patient from going to a life-threatening condition. So it includes a lot of things, including airway. You stabilize the patient. You have to manage the patient before the patient goes into a life-threatening condition. And as we said, critical care can be given anywhere. It was later, oh no, some years ago or previously, it was noted that there was a gap. As there were ICU, there were emergency medicine department, there are wards or floor, there are home or rehabilitation. There were a gap between those sections. But nowadays, we want these sections to be integrated together. That's the critical care should be provided anywhere, at home if possible, in the scene if it's a pre-hospital, at the ICU, in the ward, even post-ICU discharge, the patient has to be monitored. And if he needs or she needs any critical care, that care should be provided to that place. And that will prevent so many outcomes, and will actually improve outcome of the patient, and it will prevent unnecessary complication, which might have been prevented if we have been intervened that patient earlier. So what we want to emphasize is whenever wherever you are, you have to monitor a patient, and wherever you see that patient is starting to deteriorate, before he deteriorates, you have to do something in order to prevent deterioration, in order to prevent complications. So that's you are giving is critical care. It can be in terms of airway management, it can be in terms of vasopressor, in terms of fluid, in terms of resuscitation. So you are doing something to prevent that patient from succumbing or from dying. You are preventing that patient from getting too much complication from that condition. So that we call critical care. And so intensive care unit will proceed to be there. That's a specialized space where we put patients for monitoring, but it doesn't mean that if the patient is not in the intensive care, it has not or should not receive critical care. So critical care should be given wherever the patient is, whether it is emergency, in the ward, whatever. So we should provide critical care. That's the emphasis. I think we can proceed. So there is a scenario. There's an example, there's a scenario there. We want to discuss together. So you are working in a rural hospital. The nearest hospital with an ICU is 90 miles away by ambulance. But the roads are closed today due to inclement weather. So it's difficult even to reach to the ICU. And this morning on medical ward round, you saw a 54-year-old male patient with a history of coronary artery disease, hypertension, and a type 2 diabetic mellitus, admitted to the inpatient ward 3 days ago with COVID-19. So this patient is comorbidities, admitted with COVID-19 3 days ago. His chief complaint is shortness of breath. And on round in the morning, you note he was slightly tachypnic, the respiratory rate 27 breaths per minute, but still speaking in full sentences. That means, and then okay, you tell us what does it mean. Then he requires oxygen by nasal prongs at 3 liters per minute. He has a few crackles on lung exam, and his exam is otherwise unremarkable. And on the vital signs, these are the vital signs for these patients. Respiratory rate 27, temperature 37.9 degrees Celsius, heart rate 95 beats per minute, and the non-invasive blood pressure 107/59 millimeter mercury. Saturation is 92. Remember, this patient is on 3 liters per minute on the nasal prongs. So my question to you is, what's your interpretation of the patient vital signs and the physical exam? So I want us to respond on the chat box. From these findings and the vital signs, from the physical examination, the vital signs presented with the patient, how do you interpret this vital sign and the physical exam? So I welcome anybody just to be free to say, what do you think about this vital sign? What do you think about these findings on the examination? Just write on the chat box. So karibuni, anataka tu muandike tufanye interpretation kwamba hivi vital signs na assessment iliyofanyika vinamaanisha nini. Just write on the chat box, what do you think? How would you have interpreted these findings? Anybody to respond? How is the respiratory rate? Is it normal? How the temperature? Is this normal? Is the heart rate normal? Is the blood pressure normal? Is the saturation normal? That's the thing I want to see on the chat box. You just say, what do you think those vital signs do they mean to you? Are they normal, within normal range? Are they deranged? If they're deranged, then you tell us which one is deranged. Karibuni.
Yes, Rebecca, we have a response from Mtiga.
Yes.
Mtiga, he's saying the patient is tachypneic at 25 cycles per minute, and he's also his hypoxia. We also have a response from Saumu Hassan, who says the patient had fever, tachypnea, and he's hypotensive. So far we have two responses from those two participants who are saying that the patient, some of the vitals are not stable.
Okay, thank you so much for those who have responded. I think we all agree this patient is tachypneic, okay, slightly. The respiratory rate is 27, but again, the saturation is low from the normal range. We know that the normal range of saturation, that's low. So the patient looks to be hypoxemic. Okay, so we can see, yeah, thank you so much. So those are the vital signs, normal. Okay, so you can just look and see that the saturation is low, because we know the normal is 95 to 100, but the blood pressure may look low, but it's not not that much, because we know blood pressure is for now. Yes. Okay. The heart rate is in the upper limit. So it's within normal range, but it's a higher limit. So it's soon to be tachycardic probably. And the temperature, as we have said, is okay. Okay, so thank you so much for those who have responded this one. I think we can proceed. So now we are going to the practice number 2. We need to understand saturation goals for oxygen therapy. This is another part we need to discuss shortly. So we are continuing the same patient whom we were dealing with the previous case. So the patient was on 3 liters per minute by nasal cannula, and we saw the saturation was 92%. But 2 hours later, the patient saturation decreased to 86%. Okay. And when you arrive, he appears to be more tachypneic and is working harder to breathe. He can only speak 2 to 3 words at a time. So this patient has changed from the previous findings. Now the dyspnea has worsened, the tachypneic has worsened, the patient is struggling to breathe, and they cannot even speak 2 to 3 words at a time. It means the patient in severe respiratory distress. So the issue is, what is the goal saturation in this adult patient male, and what intervention should be taken for this patient? So That's the answer I want, the question I need you to reply. So from this finding, now the saturation is 86% on 3 liters per minute oxygen nasal cannula. The patient is more tachypnic, is working harder to breathe. Okay, and they can only speak 2 to 3 words at a time. So what do you think should be the goal saturation? And what intervention should we do at this time? I welcome for responses from you. What do you think should we do now? And what do you think should be the goal SPO2 for this patient? So any response, I welcome. Okay. Anyone with any idea? Unaweza ukaandika tu kwenye chat unafikiria nini SPO2 goal iwe kiasi gani na nini kifanyike kwa sasa hivi? Okay, kuna response nimeona from Privatus to change oxygen delivery device. Then if patient still desaturated, we can intubate the patient. Thank you so much, Privatus, for your response. Is there anyone with another option? Yes, thank you so much, Victor. Goal SPO2 should be more than 95%. And the response, we should change nasal prong to face mask. Thank you so much, Victor. Kama kuna mwingine wa mwisho. Okay, for the sake of time, I think we can proceed. Okay, thank you so much, Yahaya. Yahaya amesema we should change device to increase volume. Anamaanisha, nafikiri anamaanisha volume ya oxygen. Okay, Kevin, can we see now? Okay. So we have been discussing so many times about this oxygen saturation goals. So this is not a new thing we are discussing here, and the detail I think Kevin will share with you the links, and you can to the link, and you can go in detail. So this is the recommendation. If you are dealing with an acute adult ill patient with acute respiratory failure or acute adult patient with acute respiratory failure, the recommendation are you have to give oxygen with a goal target of 92 to 96. So our goal should be not higher than 96%. That's the recommendation, strongly recommended. Okay, but remember, it doesn't apply to all patients. There are some exceptions. Okay, so when our patients about their oxygen requirement should not go with this recommendation. Okay, for those patients with chronic respiratory failure, again, we have been discussing this several times, that you should consider that we should consider oxygen when the saturation is less than 88%. This again we have been discussing. So their goal target is between 90 to 92, 88 to 92. So those patients with chronic respiratory failure, you should not give oxygen if their saturation is 88 to 92. Unless it's less than 88, again, you can give oxygen. Another recommendation, the upper limit, yes. This applies to the acute ill adult medical patients who are already receiving oxygen therapy, like the one we are having. Again, it's the same thing you have been discussing. Their target, we want to be around 96, 97%. So once the target has been reached, you don't need to give more oxygen because that's the target we want. But remember, again, I said there are some exceptions. There are those patients whom oxygen for them is like mandatory, should not deprive giving them oxygen, like carbon monoxide poisoning, those patients with cluster headache, sickle cell crisis, patient with pneumothorax, okay? So then you should give oxygen without following this, okay? So this applies to only acute patients already receiving oxygen therapy, including critical ill surgical patients. Okay. Another recommendation for lower limit is for those patients with acute stroke, acute myocardial infarction. It is recommended to this patient that the oxygen saturation, the lower limit should be 90, between 90 to 92. Okay, of course, studies have shown that there's no difference in the outcome, even if you give them more oxygen to this patient. So that's why they don't recommend giving oxygen if their saturation is between 90 to 92, unless it's below this one, below this range, 90 to 92, you can consider giving them oxygen. So we say that if the saturation is between 90 to 92, we don't suggest providing oxygen therapy to this one. Okay, and
maybe Rebecca, on addition to that,
yes,
we have to remember that these findings are more expert opinions. That's why they have some recommendation. With some of them has strong evidence, some of them has weak evidence. So all in all, we should also individualize patients. We should make sure that we individualize patients when we are giving oxygen, and we have our own target of oxygen depending from the baseline. So we can use these recommendations and these evidences, but we have to also to think about the clinical background of the patient at the scene, and also we should also think of the baseline of the patient at that particular moment. Thank you.
Thank you so much, Saria, for that comment. Of course, that's a very nice thing to consider. You should treat every patient individually. So other patients, they have other issues, we should consider them differently. But again, we can follow this one, but without neglecting other specific issues on that patient. The other recommendation, I think this should be the last one. Again, it applies to the same patient with acute stroke or acute myocardial infarction. I think this, again, we have been discussing. That the other recommendation, they say oxygen saturation of greater than 92. This patient, they're not recommended to be given oxygen. So if the saturation is 93 and greater, the oxygen is not indicated. But again, as Dr. Saria said, this has to be individualized. Don't generalize all patients, because as I said earlier, there are some exceptions. So you should see the patient, and you should treat the patient individually, not generalized. So those are the recommendations, and those are the goal for oxygen therapy. So coming back to this patient, as people have been suggesting that what recommendation, what intervention, I think you can change also device. I agree for those said we can change device. Now it's a nasal cannula. You can use other device which delivers more oxygen, and I see there is that. And if it doesn't, again, you go higher. We have been discussing this different delivery method. I think you don't need to discuss more. Unless for those new who have not been in the previous session, Dr. Kev can share with you the link. Then you can go in detail and read about a different method of oxygen delivery. Okay, so again, let's proceed with this case. Now, new vital signs are obtained for this patient. The respiratory rate 32 breaths per minute, temperature 39 degrees Celsius, heart rate is 115, and the blood pressure now is 83/55, the saturation 86. I think the same patient we have been discussing. So intervention, as we have been discussing, you can think now, if you have these vital signs, will you give face mask, or what will you decide now from these vital signs? Which intervention are you going to do with this patient? I think let us discuss this and end up here. This patient has tachypneic, is having fever. The heart rate now is 115. The blood pressure is dropping. Now it's 83/55. What's our next plan? Are we still continue with our face mask, or what are we going to do? Any idea? So because of time, what is required is you need to closely follow up the patient. Now, the issue is here, you have to know the status, also the mental status of the patient. If the patient decides to be deteriorating, becoming unconscious, then you need to think of other invasive method of managing this patient, because probably it's going to respiratory failure. And having fevers and having low blood pressure, there are so many issues, again, you need to deal with them. So we are discussing oxygen, yes, but this patient needs other intervention, not only oxygen, because you can see now the blood pressure is dropping. This patient, if you are not careful, you may lose the patient. So you have to manage the patient in totality. But remembering, because in terms of oxygenation, you have to think of invasive versus non-invasive methods. So if you think non-invasive method can assist, you can proceed. But if you think the patient cannot cope with non-invasive methods we have been discussing, then you can think of invasive methods. So it means you can think of intubating. If the patient is deteriorating and you see you are doing something and then nothing is improving, then you have to decide what's the next action to do in order to save this patient. Thank you so much.
Okay, thank you very much, Rebecca. I think we have done the first session of this, the first part of this session, which was all about the definition of the continuum of care, of the critical care, the target of oxygen saturation. We are now moving to the second part of this session, and this is all about defining there are some different terminology we are using, especially when you are dealing with the critical care patient. And this includes things like use of meals and the QCSI. So I would like to welcome Dr. Gibbons. As I said, Dr. Gibbons is a critical care specialist in training. So I'm sure this will be a very, very, very interesting topic for all of us to learn from the guru. Dr. Gibbons, you're welcome.
Thank you. Thank you very much, Dr. Saria. Good afternoon to everyone. As Dr. Saria has already introduced, my name is Gibbons from Bears on Refill Hospital. And I would like to thank Dr. Rebecca for taking us through the very first part. And we'll continue with the second part, which will be talking a little bit on using clinical scores. And in summary, that means from where we came from, we already know what is critical care. We know the locations where critical care can be provided. And we have been taken through the difference between critical care and ICU already. And on top of that, we have been given the different target values for different conditions when it comes to oxygen levels. Now that we know critical care is a timely based interventions which you are trying to run against the organ failure. So is there anything that maybe we can do to prevent any organ failure? This will be the part that we'll be discussing soon now. So we'll go through QSOFA, MUSE, and the QSI scores. We have the very first question, which wants us to see with among all these listed things, sepsis, systemic inflammatory response syndrome, respiratory failure, acute respiratory distress syndrome, can be determined by using any score. That is the meaning behind that question. Which of the following are possible differential diagnoses for signs and symptoms using NS? Do you think you can use NS score to determine any of these things? You can chat for just 1 minute, put your answer, and then we'll continue the discussion. Very fast. It's just a matter of writing 1, 2, 3, 4, or 5. Just a number. Don't write the words. A number. And there's no wrong or right answer, as we have said. Any number which comes in your mind as any answer, you put thank you. Saum, we have 5. She thinks all of them. We can try to use scores to try to identify the risk for them. Victor also thinks all of them. Thank you. Esther, Dr. Esther Lazaro thinks all of them. Privato thinks all of them. And great. I think there's no need to wait any further. We all agree that all of these conditions which have been listed above there we can't try to use specific scores to try to determine the risk of patient ending up with any one of these disorder into its severity or severe form and end up with organ failure. So can we scroll further? We will see which ones fits where among these risk scores that we have, we will discuss. So QSOFA. Here, we have to know what is the meaning first of all. QSOFA is a quick sequential organ failure assessment. So it's an assessment you're using to assess organ failure very quickly. Any patient who is in a critical condition, that you can apply this score to determine is there any risk of losing the organ or not, so that you can take that critical care much, much more early. So that, as we can see from the link, it uses 3 parameters. And it's very simple. It's systolic blood pressure at a specific level. Most of us ikiwa chini ya 100, tunatumia respiratory rate more than 22, or altered mental status. DCS, any value of DCS below 15 is alteration. So 14, 13, 12 does not matter. And every single one of this one will be given a specific number. So it's either 0 or 1. Cool. Kama iko kwenye normal range, it's just 0. It's above normal range, it's outside of the normal range, it's just 1. Then you totalize, so total is 3. Once you put the total, anything above 2, that particular patient is in a high risk of ending up with an organ failure. Kwa utachukua hatua mapema, utaactivate team ambayo inahusika kuweza kumwassess mgonjwa. So simply that is it. And which is why it's called quick. Hii inatumika sehemu kubwa sana maudini kwa ajili ya kuweza kuidentify wagonjwa ambao wana risk, msije mkakaa nao sana before you decide to take them to the required place where they can be taken care much more better, be it in the intensive care if you have it at your hospital. So ilikuwa applied sana kwa wagonjwa wa sepsis and any disorders related to infections. That is when it was seemed to be very perfect and works very better in the identification of those patients. Can we go up? Thank you. And then we have another terminology, another score, MUSE. This one is the modified early warning score, modified early warning score. So again, is a score which usually is trying to determine the degree of severity of the illness of the patient, the ways they are changing, the dynamics, that you have received a patient who is able to speak with you, they can sit on the bed, at least they can do that. Then after some time, maybe you find that patient is no longer able to speak to you, they cannot even sit and do anything by themselves. You have a baby there who was able to breastfeed. After some few minutes or hours, unakuja kuambiwa na mama that my baby cannot even breastfeed by himself or herself. Something has changed. There is a dynamic. Somebody was doing this way, which was maybe better pre-admission or was a primary one, but now they seem to be going further and further towards the worst. Now, you need to intervene early, and this score can be applied and can be used. In different parameters, of which if we scroll up there, we will see them. So again, systolic blood pressure in different values or ranges. We have the heart rate in different values and ranges, and every single parameter that we have with the specific numbers which they correlate, you will have also numbers termed to that score. Alafu, those numbers which you get from whatever the value, you will have to totalize and get your total score. That total score will put your patient into a specific risk. Either you are dealing with someone who is in mild changes, moderate changes, or severe changes, which means you need to take an action now. So in terms of augmentation, we use the simplest and the fastest one, AVBU score. So you check if the patient is alert. If not, are they responding to any verbal? If not, they respond to pain. If they're not, that means they are unresponsive. If you are in U, this usually it correlates with a DCS of 8 and below. 8 and below. Basically, your patient is in already some comatose stage. So it's bad, severe, and you need to know what will be the response to be taken. But most of the time for this news, even if you don't have this kind of a software, we used to have papers which have been printed, and you can print them in color-coded. You print them in color-coded, every single parameter: respiratory rate, systolic blood pressure, temperature, ADQ score, and those ranges you see, which have been put in there, for example, temperature less than 35, 35 to 38, or above 38, they will be put also in a specific color code, whether it's yellow or, whether it's green or yellow or red, similar like a traffic light. If you have green, that means you're good, at least you're good to go. Yellow, 50-50, there's a danger somewhere close. You're in red, that means totally there's a danger, and you have to respond according to that. I think that is understood. Similar. So we can have them simplified, printed, put them in our bedsides, and then we can correlate them with our day-to-day arrangement and assessment. Now, if you take on your views, these are the things that we are doing them in every single day. It's just to follow and some protocols to make sure that we can identify someone in risk and respond so fast. Thank you. I think there's nothing much here we can talk. We could scroll up and continue with the next part. So we have again the quick COVID severity index score. It's quick COVID severity, COVID-19 severity index score. So also similar sort of a score, but specifically for the COVID-19 patients. Basically, you are trying to do identification of a COVID-19 patient who is in a high risk to deteriorate in terms of respiratory illness within the very first 24 hours of admission. Huyu sasa umemwadmit masaa 24 ya kwanza, unaweza ukawa unatumia hii score kuweza kuona yupi yuko kwenye riski kubwa zaidi ya kwenda kwenye deterioration zaidi, ambaye atahitaji escalation ya care au kuongeza aggressiveness towards their management within those first 24 hours. Also, it uses 3 parameters for it, just like the quick SOFA, but they're to be spent. One of them is here and there, the respiratory rate, but here 2 parameters, again, are different a little bit. A pulse oximetry, that means oxygen saturation by pulse oximetry, the levels which I've seen there when Dr. Rebecca was discussing with us. And now they have been given here in different levels and in different numbers and different scores. Then the third parameter is how much oxygen do they need in liters per minute. So you will put and totalize according to what is being given. Somebody is there, they are in 10 liters per minute, SpO2 is maybe 90 or 75. Check respiratory rate, 30. So you go to the respiratory rate, you look at that state, where does it fall? You check that SpO2 of 75, where does it fall? The flow meter of 10 liters, where does it fall? And every single one, it will give you a specific score of which you will totalize. Mara nyingi nakujaga na total ya 12. And then this 12 will be divided into different risks of severities, all the way to the most severe one, ambayo inaenda mpaka kwenye 12. So once you get those ones in higher risk, moderate to severe, you know for sure these ones, they will need much more close observation and maybe even more review from the seniors or anybody who is highly expertise in that particular area of care. So, as you can see, we scroll up, you see different values and the total which it gives you, and it will give you also the total score. Thank you. Can we scroll up and continue? I think here we have nothing more. Yes, so we know at least these 3 simplified systems or scoring systems that we can use in our everyday practice. The things that we are using, the things that we are doing in every single patient is just to put them into one compact thing to get a score and to get a presumptive risk assessment and then to respond to that risk. Thank you. So now we are going to that particular part. We have scored the patient. We know they're in a risk now. So how do we respond? What do we do? We have already picked those in high risk. So there's another concept of rapid response systems or teams that can be formed within our hospitals. These are simply the teams which should be there and special to respond to these critical events which are happening in different sub-departments or units within our hospitals, all the way back ICU. So ni team ambazo zina comprise watu tofauti, it will comprise different members. Sawa, from different expertise. And zinaweza zikawa zinaongozwa, or they can be led by physicians, or they can be nursing led in those particular team. Nursing led, it seems to be the most simplest one and easier and simple and cheap also. It does not require too much cost because all the time you'll be having nurses in every particular shift compared to physicians, of which most of the time you will have to call them from maybe home, especially outside of the working hours. So nurse-led rapid response teams, they are mostly preferred. And even I think in our environment, they could be the best option to be thought rather than physician-led. So those are the teams. Systems here again, different concept before we go down here so that we finish further once we understand. System, this means these teams which are existing in our hospital, they cannot work by themselves and become productive if they are not supported by the system from the administration. So administration also should be involved in order to be able to simplify the work of these rapid response teams in terms of personnel, in terms of expertise, training, as well as equipment. You can have the teams, you don't have equipment to respond, then work done will be equals to 0. Thank you. Can we scroll up? Can we scroll up? Thank you. So we have the same patient whom we started up there. Now this is a situation. Suddenly, the patient happened to lose consciousness. It means you can't even communicate with him. The new vital signs you check, you find the respiratory rate of 40, temperature from 37, now is 39, heart rate is 147, pressure which was 100 and something systolic now, systolic is 63 and diastolic of 25. And SpO2, which was in early 90s, I think it was 92, now it is gone down to 66%. So can we scroll up? Thank you. And great. So the question is, among all those signs and the parameters that we have seen up now, which ones do we think they need a very immediate intervention? That from what I see now, I think I have to do something with regard to this respiratory rate, or maybe the temperature, or maybe the heart rate, or maybe the pressure, or the SpO2. Which one do we think they need immediate response or intervention? Maybe we can have less than a minute to just put anything that you think. So if it's respiratory rate, you can put RR there in capital letters, temperature put T, heart rate put HR, BP just put BP, SpO2 just put SpO2 in the chat box. Anything that you think. If all of them, you just write all of them. Anything? But okay, so yeah, since BP should be taken care right away. Priva airway intervention first. And I don't know what do you mean exactly by airway here. With oxygen or with bed, and NABP and SpO2 from Simon. Thank you. Saturation. Okay. Thank you. So even without scrolling further upward, these are the ranges that we can see. And from whatever we have from our patient, you can see that almost all those parameters, they seem to be totally out of the normal ranges, and almost all of them, they need intervention. So when we have those teams that we are calling them rapid response teams, they can be having charts like this one, so that when they see on a particular patient that they have assessed, they will have to know that this is alarming. So now I have to either respond by doing what? Two types of response. Either that particular person who is assessing the patient right now might have the ability to respond on that bedside. If they don't, or they think they can't, then they have to call the team from their team leader of that rapid response team to come and review the patient and continue with what should be the management. So it's either you yourself who is assessing the patient there. If you're able to respond to the management, kwamba pressure imeshuka, pengine maybe I need to give fluids, the pressure is down. This SpO2 has gone down. Maybe I need to put oxygen from nasal to face, if not from the face mask to the reservoir bag. If not reservoir bag, maybe to put the patient on the CPAP in the ventilator. If you think you cannot do, then you call one of the team leader in your rapid response team to come and review that particular patient. And different criteria can be used and in different organ systems. So outside of that, we have been given other ones which are extra, which can be clinical judgment. So for this particular case, even if we scroll up, I think you will all agree that almost a single thing there needs to be paid attention to and intervened. Because you can't rate this one too much. Some of them, maybe they might come much more better with intervention of other things. Mostly, if you increase the blood pressure, you might find even the heart rate is going down from the response of the blood pressure. You make SpO2 better, probably, maybe your patient consciousness might start to become better. You control the temperature towards the normal, you might find maybe your patient is starting to respond also. The conscious level is becoming better. So, great, thank you. Can we go up and go to the second one? And here is which of the following intervention may be needed for this patient. Okay, so again, a choice. Higher level of care. That means if you are in the lower health care, you don't have maybe an ICU, probably yes. It's too severe, probably it's already in a shock. Comatose, probably that disease might be something that needs intubation to continue the mechanical ventilation, which maybe you might not have in your center. So probably yes, higher level of care. Increased oxygen sleep, we have all agreed. More frequent monitor, we have all agreed that this patient will need more close and ongoing resuscitation, yes, for sure. And airway management, you have already said it by yourself that probably we need to secure the airway, maybe even by intubation and put the patient on the vent. So I think we'll agree that all of the above are correct. It should be possible to be done to this particular patient. Can we scroll up further? Thank you. So here there's a question a little bit on our own settings and our own setup. Do we have these kind of teams set up in our hospitals or health centers that if there's a problem, and in this particular ward, medical ward, surgical ward, there's a pediatric ward, there are specific people who are known to be able to be responding to these critical events and to activate the team and the team to see what could be the further progress or management towards that particular patient. Either atoke pale alipokuwepo kwenye ward, pengine apelekwe ICU, or maybe it could be somebody who might need this totally a referral to another higher center, to another different hospital that can give care which is required and appropriate for that particular patient. So it's a yes or no, maybe in a chat, and we will know for sure by ourselves. Now, if it's a no, it means if we would encourage highly that this team should be tried to be formed. Nest-led could be cheap, faster, and easier. So nest-led rapid response team should be entertained more. Kwa sababu tunakuwa na shift tatu na kila muda kuna nesi yupo somewhere in our ward. That would be my recommendation for this. Not yes, very few they have, a lot of us don't have it, almost 70%. So for those of us who do not have, I think we should think it's a high time to think that we should be having these specific teams to avoid failure or end organ damage or more deterioration to the patient who might have a chance to make it better. So can we scroll up? And there's a question, who can activate a rapid response team and for what trigger? So here we have the team special. The question is, what does this team get activated from? And whoever is going to activate or to call this team, what will be the trigger? Ni kitu gani au vitu gani vile ambavyo ataviona vinahatarisha akaita team. So triggers. anything that you think will be critical, you could put it in the chat box. Come by, if I see this or this or this, I will have to activate the rapid response team. And we have seen already up there, this team can comprise different expertise from the hospital, from physicians, nurses, and other healthcare providers within the hospitals. While you are putting on your answers, I would just like to put two things. Kwenye member selection, how do you select the member of the team? Select them with regard to 3 abilities. So 3 abilities or 3 capabilities. Anybody who should be in these teams should be able to diagnose. If you call me, I'm a team leader or a team member to come and respond, I have no idea how to diagnose, then it's a waste of time. And this particular person also should be able to initiate therapy. So if I am called there to assess and respond, I should be someone who is also able to initiate the required therapy right away. So nakuja alafu siwezi kufanya chochote na sina mandate ya kufanya chochote, then it's useless. So the last part or criteria, it should be someone who, if they find that particular person is in a pretty bad shape, that you cannot take care, there should be people with the authority to transfer the patient to another higher hospital or another hospital at all. Or from the ward, maybe to another unit, especially the intensive care, kwamba huyo mtu ana authority ya kufanya hivyo, ili mgonjwa akasaidiwe. 3 things to be considered for team members. So triggers we have seen is vital signs. A lot of different vital signs, they can be triggers. Anything which is totally away abnormally is alarming, it can be a trigger. And sometimes, even if the vitals, they are quite good, we can accept even the feeling from the healthcare giver or the guardian or the parent or someone who's taking care of that patient. They have a concern that there is a change in the condition of that particular patient. So even if everything else is normal, but someone who is staying with that particular patient for most of the time, taking care of them, they are concerned that there is something wrong. Well, then you can activate your team to come and assess the patient, or if you are the one who can assess, you are able to do that, you can start the assessment, then activate the team to come and do much more further of what you are not supposed to be doing or you can't do. I think that is clear and understandable. So these things are the things that we should be printing them, we should be having them, and everybody should be able to see them. So we have agreed on that. Now we know what are the triggers, any danger signs, or even a concern from caregiver, either a medical personnel or relative. And then the team should be comprised of different people from different expertise. Tumeona criteria za selection ya team members, what are they supposed to do? Goals for this team before we go further should be at least known. So the biggest goals as to why we have these teams is to be able to identify a patient at risk, high risk of deterioration, so that they can be taken care in a timely and proper manner. To be able to communicate with other people from either within the hospital to another department, like example ICU, or to other hospitals that we think we can transfer this patient. So it will make communication much more easy and better. And then effective management of that particular patient can be facilitated with having these teams. Once we have diagnosed very faster, we can start effective and appropriate management to avoid those further deterioration. And then lastly, these teams, they can help delayments in transferring patients either from the ward to the ICUs or from that particular health center or hospital to another higher center if it's something that they cannot handle by themselves there. So at least those 4 goals should be known by everyone. And can we go further? Up, scroll, thank you. And what provider should respond to this patient deterioration? So this is a question as who should respond. We have seen the condition, we have seen the team components, members, and who can respond. So we said this team can have physicians, nurses, lab technicians, microbiologists, watu wa quality improvement, infectious, all those people can be involved in these particular teams. Now, with this particular case that we have, responders can be any sort of those people from any different groups. either be physicians, the nurses themselves, lab technician to be called, we are concerned of sepsis here, we need to do cultures and blah, blah, blah. What do we do? Pharmacist, which kind of medications would be better to cover these particular patients, and people dealing with the oxygen therapy system or oxygen system that maybe we need this and this. We have only concentrator, we need cylinders now. With this concentrator, we cannot make it. So all of those things. And all of those kind of different people from different expertise, I think, should be able to be involved in this particular patient. Can we go up? And we have another component here. Who are the stakeholders needed to implement rapid response system? I think we have already answered it in the very beginning of our discussion. We said is rapid response systems, administrative part, rapid response teams. These are the effectors, the teams on the ground, which will comprise the people who will be on the scene. So the systems, different administrative from different sub-specialties. Ones here are directors, you have Wasibu from accounting office, to facilitate the money, ways a bit in quality improvement to see which are the places we can improve ourselves, we can be better. So all those administrative blocks also should be involved to make sure that these teams, rapid response teams, they are effective and productive in our places. And there's the last part here, I think, before we go any further, which asks about documentation, which should occur. So documentation is a patient who is deteriorating in a critical condition. What sort of documentation would you think you would need to put down for further references? Anything that you think should be put in there, you could put in a chat box in less than a minute, and then we could scroll up. So we can go up. So there's an example there. Can we go up? So it's a form, which if you look at it, at the end of the day, it has different parts, basically covering the history, prior, the physical assessment that you do, different parameters that you can have in different organ systems, and what will be the response from the patient from all those things that you have done, the intervention that you could have done, and status of the airway, all the way, the ABC, circulation, and the breathing is given in there. And the last part, which talks about interventions that were done in terms of medications or any other intervention. And where does the patient happen to end after you have concluded that this patient is in a high risk of deteriorating? Did you take the patient to the ICU, transfer the patient to another hospital, or you had made another decision otherwise? There will be some other things that we don't have here much in our places. Kuna kitu kimeandikwa made DNR or CMO. DNRs do not resuscitate protocols. These are the patients that you think once you assess them, they're just going to die one way or the other. Without therapies, they're going to die. So there's no reason for you to say you are going to aggravate your management, because it's going to be a waste of resource and energy, time, plus also the false hope to the relatives. Ambapo kuendelea huyo mgonjwa kumkalisha kwenye ventilator, for example, wakati ubongo umeshakufa, wataendelea kulipa hela za hospitali admission, lakini mgonjwa wao atakuja kufa siku 5 zijazo, watakuja kulipa tena za siku 5 zijazo ambazo basically ameshafariki tangu ubongo umekufa. So wenzetu wana hizo sheria kwamba kwa mazingira ya mgonjwa huyu tukimwona hivi, hata kwenda kusukuma kifua akipata cardiac arrest hakuna sababu, and everybody will know. So that is the DNR. We don't have that protocol yet. It's a system that should be protocolized and put in the real legal system. Kila mmoja ajue na anajua sheria zake. And that was it, which means a form like this can be printed and it will be filled up by the teams. I think that's it for the part that you were supposed to discuss.
Thank you so much, Dr. Gibbons, for the very well narrated presentation. I'm sure by now everyone of us knows about the QISAI, the SOFA, and the modified L warning signs. And I'm sure at the end of this presentation, majority of us in our facility, we are going to establish these protocols. And if not, we are going to also to, if possible, we're going to form the teams Now, having seen that, now let us discuss about the last part of this presentation is about the implementation of the rapid response system or rapid response team. So far, we have seen the importance of having this system and the team. So, but as a team, we need to have a regular meetings. We need to develop some policies, some protocols. We need to have a regular review of the policies and the protocols so that we need to sit down with the quality improvement team to ensure that we are up to date and we see the gaps and identify the gaps and work on that. So to take us through those implementation issues of the rapid response system, I now welcome Dr. Leticia Komba to take us through this last part of this session. Thank you. Dr. Leticia, welcome.
Good evening. Si kama nasikika, maana internet yangu ipo unstable. Implementation ya rapid response team ni almost ni kama summary vyote ambavyo tumesikia huko juu, especially presentation ya Dr. Gibbons, kwa maana kwamba ili uimplement lazima kwamba kwanza udefine hiyo response team yako unataka icomprise nani. Unajua hiyo team comprise nani na nani, unatakiwa pia uweze kuidentify role ya kila member kwenye hiyo rapid response team. Apart from that, itatakiwa pia lazima ipate support kama Dr. Gibbons alivyosema. Timu inaweza ikawapo, lakini kama hamna support from administrators na system nzima kusupport hiyo team, kwa maana kwamba equipment, resources, au watu watashutuliwa, hiyo rapid response team inaweza ikawa ni useless. Sasa kwenye kuimplement hiyo unaweza kutumia kwa kifupi hicho ambacho hapo kimeandikwa SEDA, ambapo ina comprise situation, evaluation, decision and action. Naomba uscroll juu tuangalie kile kimoja hapo kina nini na nini ndani. Okay. So kwenye situation, wakati unataka kuimplement hiyo rapid response team, inabidi ujue kwamba aim kubwa ya hiyo rapid response team ni itakuwa na uwezekano mkubwa wa kuimprove patient outcomes. Lakini vile vile hiyo timu yako lazima iwe na uwezo wa kuidentify warning signs before ya kupata complication ya hiyo situation ambayo mgonjwa anakuwa amepata that particular time. Kwa maana ipi? Kwamba hiyo team au members wa kwenye hiyo team wao na uwezo wa kujua signs zote ambazo zinaweza labda zikadili na respiratory au cardiac arrest. And then hiyo rapid response system iweze kuprovide hiyo critical care timely, kama gimoni action, action kama ni consult, kama ni provide any critical care service iwe based na time. Ina maana usiruhusu any unnecessary delayment. Ukiruhusu necessary delayment, ina maana hiyo rapid response team itakuwa ni almost useless. And then uweze pia kuevaluate hiyo timu yako. Na kwenye evaluation utafanya vipi? Lazima uwe na RRT policy ambayo umedocument kwenye institution yako, na vile vile kama nilivyosema mwanzo, identify key stakeholders kama physician, families. Kama family unaweza ikawa una utaratibu wako umejiwekea kwamba kama hospitali kwako unakaa na mgonjwa ambaye labda anaweza akawa na family na mtaarifu fulani, then hiyo team hiyo responsible, sio kwamba neglect information tumepata kutoka kwa mtu fulani na fulani. Na maana uweze hivyo vitu vyote viwe documented na viwe communicated, kila mtu ajue kwamba akipata information kutoka kwa mtu fulani, hiyo information inabidi iwafikie rapid response team, ambao rapid response team ndani yao wao ambao wanaweza okay, thank you. So what else should be done so as to implement that rapid response system? You need also to formulate a rapid response committee in which it will be making the follow-up, making that team is functioning well and trying to rule out any barriers which might hinder the objective of that team. And then we should, that rapid response team should also adapt some protocols according to that particular institution. For example, maybe a certain hospital has its protocol, how to deal with the patient with maybe a COVID patient or a septic shock patient. So those protocols should be adapted through that rapid response system, rapid response team, so that they can also provide care according to that protocol. So can you please click that button so that you can see a certain protocol which was formulated somewhere? Oh. Is it this one? Okay, I was expecting a certain protocol which was adapted as a modified early warning score system, which was adapted somewhere, in which they adopted by including a component of how to identify a critical ill patient who is a COVID patient. But I think it is not seen there. So let's go next. So in summary, during the implementation of the rapid response system, we should follow these steps, whereby we need to define the rapid response team. In a certain institution, what do we need? What do we mean by having that rapid response team? It should be defined. What is the objective? What does it mean? And then what is the purpose of that response team? And who will activate that response team? Because the rapid response team, it will be a certain team comprising maybe an emergency physician, doctor, or a ICU nurse, or resident, or register. But who will activate that team? Is it a nurse who is in duty? Is it a specialist who is in duty? Is it just a relative? So it should be identified who will activate that response team. And then we need to create a certain criteria, maybe using those protocols. For example, that protocol which Dr. Gibbons was talking about, a modified early warning score protocol. And it has to be displayed somewhere so that somebody will be looking on those parameters. And if the score is maybe below 5, and then they can activate that rapid response team so that they can come and give the critical care to that patient before deterioration occurs with that particular patient. And then we need to define the procedures for the activating of that rapid response team. For example, who will call that team? It should be defined well. And then how? How do they call? Is it using phone calls maybe, or they should shout, or they should go somewhere where they can tell somebody we need that help so that rapid response team should arrive to a certain ward. It should all be stipulated somewhere and should be clear to everyone. And then who are the members of that rapid response team? We should also be clear, and what expertise will they bring? Gibbon said that team should be a team whereby it will bring something. That means it will bring care to that patient who needs that critical care, maybe outside of the ICU. So that team should be for those who have different maybe knowledge or capabilities, so that they can rescue those patients who are critically patients who have an emergency, so that they cannot end up deteriorating because of those members have no, they don't have that capability of providing that care. So the expertise should be well known to all members within that team. And then the roles of that team should also be known. We should be defined what are their roles for each member in that group. But again, can I scroll a little bit up? Okay. Also, we know that team is there, but we need support from the stakeholders. For example, those administrators should support that team, so that team should have those medications, maybe some of the drugs, some of the equipment, because the team is not just the human resources. It goes in hand with the medication and other equipment. So these things also should be defined well. Where should this supplies be found and who will bring it during that call? And then we should now know if the rapid response team has done their job. Maybe they've already stabilized the patient. Where will this patient be disposed? If the patient has been deceased, where will this patient go? Or will this patient go to the ICU now to continue with intensive care? Or should this patient be referred to higher level so that it can benefit from other medical cares? So this also should be well known to that team. That rapid response team is not necessarily that they will do everything. They will also be able to dispose this patient from where they provided that care to the next step. Thank you. So what is the key learning point? So what is the key learning point from this discussion today? Saria, are you keeping going or should go? Saria?
I think Leticia, you can just wind up.
Okay, we have learned that.
Thank you.
Okay, so we learned that critical care is a true care inside the ICU. I think that is the first point we learned today, meaning that you can provide a critical care service anywhere. It is not necessarily being in the intensive care unit. The thing you need to know is who should provide that care, with what equipment or drugs. And then oxygen should be provided until it reaches 96, but this one, it will be depend on the clinical status of that patient and the need of that patient. That means it is not necessary to every patient you will provide oxygen up to 96. We need to categorize those patients according to their clinical status and their maybe comorbidities and their demand. And then we learned about how to score those patients, looking on the signs of any deterioration using QSOFA, as Gibbons explained. But again, we went through the modified early warning scores so that we can identify who patient needs critical care service and when we should call the rapid response team to provide that care. But again, we have discussed about the rapid response team in providing the critical care and the expert to the patient who are unstable patients. And again, we learn about the implementation of the rapid response team. So if there's any question? Okay, there's one point here, thorough documentation during providing those care to those critical ill patients is very important, because we need to know what patient went through and when you provided what and who provided those things. So documentation is part and parcel of critical care services, because our services goes in and end with time. So, and there's no time delayment in provision of critical care services. Thank you.
All right, thank you so much, Leticia. Okay, so I think we have just finalized our presentation or our session, unless if someone has any burning issue, any questions for the participant, you can just raise your hand and then you can let you speak. If you have any question, anywhere you want to be, anything you want to be clarified, now is the time for you. Okay. Okay, so Pivatus is just a comment. He's saying he is really appreciated. Thanks all panelists for your presentation. We also appreciate your participation, you know. We will. Okay, so okay. And thank you. Okay, so majority of the participants are just congratulating us for the presentation. We also appreciate your attendance for today. For today, we have just breaking the record of having 36 plus participants. So we are very glad to have many participants. So if there's no any question, I would like to say that we have just come to an end of this session. And just a reminder that starting from March, our session
Saria,
will run.
Saria,
Yes.
I think there's a hand there from Privatus.
All right, Privatus karibu.
Of course, thank you for your presentation, as I have commented there. But there is one thing that you tried to talk us on those standard guidelines like music, QSOFA, and QSSI. But in case of QS,
Privatus, can you try to come up again?
Probably the network problem, I think. Yeah, it's cut off.
So I was trying to say that starting from March, our session running twice a month. We have a session at the second week of every month, and we will have another session on the fourth week of every month, starting from the March, April, May, up to June. So starting from the next month, our session will run twice a month. So please don't. I would like to welcome all to make sure that you participate. Otherwise, I think we have come into conclusion, and then back to you, Kevin, for any announcement and the concluding remarks.
I think Dr. Saria, you can tell when should be the next session.
Okay, Dr. Kevin will do that. Thank you.
Okay, thank you.
Thank you so much, Dr. Saria, and all the panelists. Dr. Rebecca, Dr. Leticia, and also Dr. Gibbons. This was a very good learning session. And so I would just like to emphasize on the announcement that Dr. Saria has made. From next month, the month of March going forward until June, we are going to have 2 sessions per month instead of 1 session. Kama tutakuwa na session 2 kuanzia mwezi ujao, mwezi wa 3, badala ya session 1 kama tulivyokuwa nayo. Kwa hiyo kuanzia mwezi wa 3 huu unaokuja, tutakuwa na session tarehe 11 mwezi wa 3. Alafu pia tutakuwa na session tarehe 25 mwezi wa 3. Kwa hiyo session ya 6 itakuwa tarehe 11 mwezi wa 3, session ya 7 itakuwa tarehe 25 mwezi wa 3. Alafu kwa mwezi wa 4 tutakuwa na session ya 8 ambayo itakuwa tarehe 8 mwezi wa 4, na session ya 9 itakuwa tarehe 22 mwezi wa 4. Session ya 10 itakuwa tarehe 6 mwezi wa 5, na session ya 11 itakuwa tarehe 20 mwezi wa 5. na session ya mwisho ya 12 itakuwa tarehe 3 mwezi wa 6. Kwa hiyo tutakuwa na session 2 kwa mwezi. Tunawashukuru participants kwa kujoin. Tumefikia mwisho wa session yetu ya leo. Unaweza ukavisit Learning Resource Center kwa ajili ya kupata hizi presentation pamoja na recordings ambazo zimekuwa presented. Hiyo ndo link, na tutashare pia link kwenye groups, na link ya recording ya kipindi na Learning Resource Center itakuwa shared pia baada ya email. Unaweza ukajoin kundi letu la WhatsApp kwa kuscan hii code au kutuma message assist kwenye hiyo namba ambayo inaonekana hapa. Tunawakaribisha sana. Session ya 6 kama tulivyosema session ijayo itakuwa tarehe 11 mwezi wa 3 mwaka 2022. Tutakuwa tukidiscuss basic ICU care considerations. Kama una maswali kabla ya hii session, unaweza ukatuma email kwenda eco@assistinternational.org, alafu itakuwa addressed wakati wa kipindi. Tunawashukuru participants na panelists, tunawatakia jioni njema. Tutaonana kipindi kijacho. Asante. Eco India team, I think we can close the session.
Sure, thank you.